little difficult to understand and manage is unruptured ectopic. Okay, in unruptured ectopic, the triad is present only in 50% of the cases. Alright, in unruptured ectopic, the triad is in 50% of the cases, so you have to rely on your clinical knowledge, on your ultrasound, beta HCG. So in unruptured ectopic, how can we diagnose it? The best way to diagnose is transvaginal sonography. Then you can take help of beta HCG. Okay, and then there is something called as serum progesterone, which is not used nowadays, but you should know, because sometimes they ask you if this is the serum progesterone, then what is the diagnosis. Okay, so it is not useful although, but still if it is less than 5 nanogram per ml, then this is suggestive of ectopic. And what is it, that if it is more than 20 nanogram ml, this is very good. Okay, this is a good value, and this is a value that supports an intrauterine pregnancy. This value almost rules out ectopic pregnancy. Okay, all right. So also there is one more thing, you can also try synthesis. Okay, if there is unruptured pregnancy, you suspect ectopic pregnancy, and if there is bleeding inside, it could be a ruptured ectopic in its initial stages, but you are not sure. So in that case, you can do a synthesis in which you do colpotomy, posterior vaginal, from the posterior vaginal wall you put in a needle and you take out fluid. If that is blood which does not coagulate, then it shows that there is an ectopic pregnancy with a rupture. So CVS and TVS and beta HCG, transvaginal sonography is the investigation of choice. Okay, it is the investigation of choice in which you see complex adnexal mass. Okay, complex adnexal mass, and obviously the uterine cavity will be empty. This is the presence of adnexal mass by the side of the uterus, which can be moved when you move the probe, or when you move the uterus side by side, is called as blob sign. Okay, the presence of adnexal mass is called as blob sign. Okay, then there is something called as, inside the uterus you have pseudo gestational sag. Okay, and it is present in 20% of the cases. The tube, you can see in the tube a complex adnexal mass. Okay, the tube is not visible on ultrasound, so a complex adnexal mass separate from the ovary can be seen by the side of the uterus, and inside the uterus you can see a G-sac looking structure which is exactly not like it. It is a pseudo G-sac. So they ask you what is the difference between a true G-sac and a pseudo G-sac. So pseudo G-sac and a true G-sac. Okay, so pseudo G-sac is like this. It would be like this. And true G-sac is something like this. Okay. So to understand it better, I have made these diagrams. They don't really exactly look like this, but a pseudo G-sac is ovoid. It is ovoid. It is central and irregular, whereas true G-sac is round, it is eccentric, and it is regular. Okay, decidual reaction, like when there are two rings, right? So this is like decidual reaction, in which decidua capsularis and parietalis plays a role. So decidual reaction is absent in pseudo but present in true gestational sag. Okay, so this is one finding on TVS. What else can you see on TVS? There are certain signs associated with the tubal ectopic. Beagle sign. Beagle sign. When there is hemorrhage around, so it shows like a hemorrhagic ring around in the adnexa. Okay, there is a hemorrhagic ring in the adnexa. This is called as Beagle sign. Then there is on Doppler, there is ring of, when this is seen on Doppler, there is ring of fire appearance. Okay, there is ring of fire appearance. Beagle sign, ring of fire appearance, a pseudo gestational sag, and blob sign. These things are seen on TVS. Okay, but sometimes it may not be seen. We will discuss that later. But about beta HCG, you should know something called as discriminatory zone. Okay, on TVS, if there is no GSAG, like this is what I was talking to you about. If you see a complex adnexal mass, well and good. If you don't see it, then you should know that on TVS at 15 international units per liter, it should be GSAG should be visible on intrauterine. So if there is no GSAG at 1500, which is beyond the discriminatory zone, then this is suggestive of ectopic pregnancy. At 1500 international units beta HCG, GSAG should be seen on transvaginal ultrasound. Similarly, at 6000 to 6500 beta HCG, it should be visible on transabdominal ultrasound. But we are not talking about that here because beta HCG that high, we don't like, we would not want the pregnancy or the ectopic to be taken that high for us to analyze it. So this is one thing, and then second is the Kadar's principle. According to this, in first 48 hours, beta HCG should double in intrauterine viable pregnancy. Okay, so if this doesn't happen, if the discriminatory zone, if it has crossed beyond the discriminatory zone and intrauterine pregnancy can't be seen, or beta HCG is not doubling in 48 hours, then it means that it could be an ectopic pregnancy, or if it is not doubling, then apart from ectopic pregnancy, it could be a failed pregnancy or pregnancy of unknown location. So these are the three things that help us understand, come to a conclusion and make a diagnosis.